Okay, so we're diving deep into the world of respiratory therapy today.
Really interesting stuff.
We're going to be looking at the respiratory therapist multiple choice examination. And we've got a really comprehensive study guide to help us with this.
And a whole bunch of references, too.
Yeah, so if you're studying to be a respiratory therapist, this is going to be a good one for you.
You're going to be very well prepared after this deep dive.
That's the goal.
Yeah, what I think is so fascinating about this field, you know,
Mm-hmm.
it goes way beyond just the equipment.
Right.
It's really about the human respiratory system,
Yeah.
how it works, and how to help when it doesn't.
It's a big responsibility.
Absolutely.
So this exam, it seems like it really tests your ability to think like a respiratory therapist, not
Right.
just memorize a bunch of facts.
Exactly.
Right.
And, the study guide jumps right into that with
Yeah.
what it calls the 4 critical life functions.
Okay.
These are really fundamental to the whole field.
So the 4 critical life functions are, let me see if I can remember this.
Okay.
Ventilation, oxygenation,
Yes.
circulation, and perfusion.
Got it.
Okay, good.
You got it.
I was trying to make sure I could remember all 4 of them.
Well, and each one is distinct. So ventilation, that's all about moving air in and out of the lungs.
Right.
While oxygenation focuses on getting that oxygen into the blood.
Okay.
Circulation, we know that it's the heart pumping blood throughout the body.
Right.
And then perfusion, that's all about that blood actually reaching the body's tissues, delivering the oxygen and nutrients where they need to go.
Okay. Yeah, that makes
So
sense.
they all kind of work together.
So of those 4, I mean, obviously they're all crucial,
They're critical.
but is oxygenation the one that respiratory therapists focus on the most?
Precisely. Yeah, that's the one. Because, it's the most common problem that we see clinically,
Right.
making sure that patients have that vital oxygen supply.
And that's where a really thorough patient assessment comes in, right?
Absolutely, yeah.
Because you have to figure out what's going on. It's like detective work almost.
It is. And this study guide actually breaks down the whole assessment process beautifully.
Okay.
We're talking medical history,
Right.
bedside interviews, getting the patient's perspective, physical exams, really listening to the chest.
Right.
And then we have all this data, right, from x-rays to lab results. It's really putting all those pieces together.
And the study guide gets into some really specific techniques.
It does.
For example, the CAT scoring system. I'd never even heard of this before.
Okay, well, the CAT scoring system,
What is that?
it's a really practical tool that we use
Okay.
to assess a patient's ability to perform what we call activities of daily living.
Okay, so like basic things like being able to dress themselves or
Exactly.
feed themselves.
Yeah, eating, bathing, getting dressed, using the bathroom, all those essential things.
Got it. Got it.
So it gives us a really good picture of the patient's functional capacity
Okay, hey,
and helps us tailor their care plan accordingly.
that makes a lot of sense.
Another interesting detail I found in this study guide
Yeah.
was this whole concept of pack years.
Pack years.
Pack years. Yeah, when you're considering a patient's smoking history, right?
Okay.
It's basically a way to quantify someone's lifetime cigarette exposure.
Oh, okay.
So you multiply the number of packs they smoke per day
Right.
by the number of years they've smoked. So someone who smoked a pack a day for 20 years
Right.
has a 20-pack year history.
Wow.
It's a powerful indicator of their risk for lung disease.
So it's not just about if they're a current smoker or not.
Exactly.
It's about how much they've smoked over their lifetime.
Precisely.
Wow. That's really interesting. I never thought about it that way.
It really puts things into perspective.
It does. It does.
Now, kind of shifting gears a bit here.
Okay.
The study guide also takes us into the visual world
Oh, cool.
of chest x-rays, showcasing both PA and lateral views.
So this is something I'm always really curious about.
Yeah.
X-rays, just in general, like how do they work?
It's fascinating, right?
Yeah, how do you take a picture of the inside of somebody's body?
Well, it all boils down to density.
Okay.
Different tissues in our body, they absorb varying amounts of those x-rays.
Okay.
So dense tissues, like bone, they absorb more
Right.
and show up white on the image.
Okay.
We call that radiopaque.
Radiopaque. Okay.
Exactly. Whereas less dense tissues, like our air-filled lungs, they appear darker
Right.
because they allow more of those x-rays to pass through.
Right.
And that's what we call radiolucent.
Radiolucent. Okay.
So essentially what we're doing
Got it.
is looking at those
Yeah.
patterns of light and dark, the radiolucency, radiodensity, to figure out what's going on in the lungs.
So like if you see a big white spot, that could be
Could be a mass.
right or fluid buildup or something.
Exactly.
Yeah.
Exactly.
Wow, that's so cool.
So the study guide does a really good job of highlighting those key anatomical landmarks
Okay.
that help us interpret these X-rays.
Okay.
For instance, the trachea, our windpipe, should be positioned right in the center.
Right.
If it's pushed to one side,
Okay.
that could indicate a problem, like a collapsed lung,
Oh,
a
wow.
fluid buildup.
So you can see that on an X-ray.
You can. You absolutely can.
Wow, that's so cool.
And then, those sharp angles where the diaphragm meets the ribs,
Yeah.
the costophrenic angles?
I always remember seeing those on X-rays.
Right. Well, in conditions like COPD, where air gets trapped in the lungs, the diaphragm can flatten out,
Oh.
and those angles become less defined.
Really?
Yeah, it's subtle but important.
Wow, you can tell so much from an X-ray.
You can. It's like a whole language.
It is.
And, the study guide emphasizes how important the quality of the X-ray is.
Right.
If it's too dark or too light, it's like trying to read a blurry text message.
That makes sense.
You're not going to get an accurate interpretation.
Right, right.
So, speaking of ways to assess breathing,
Yes.
the study guide also gets into abnormal breath sounds,
Okay.
because we're not just looking at X-rays.
Right, you're listening to.
We're using our stethoscopes, and there are these key sounds that we listen for.
Okay, like what? What kind of sounds?
So we've got crackles, wheezes, stridor, pleural friction rub, and each one tells us something a little different.
Okay, so like crackles, are those the...
Crackles are interesting.
Okay.
Imagine like Rice Krispies
Okay.
when you're listening to someone's chest.
Oh, like when you first pour the milk in.
Exactly that kind of sound, and that often indicates fluid in the airways.
So that could be pneumonia or...
Pneumonia, pulmonary edema, things like that.
Okay, right.
Now, wheezes, those are a little different.
Okay.
Imagine a whistling sound, high-pitched, almost musical.
Okay.
Those are wheezes, often associated with narrowed airways, like in asthma.
Okay, that makes sense.
Stridor, that one's more high-pitched, harsh, almost like the airway is struggling to let air in.
Oh, okay.
And that one's serious, often caused by an obstruction in the upper airway.
Wow, so each of those sounds means something totally different.
They paint a picture.
Wow, that's fascinating.
And then lastly, pleural friction rub. This one's kind of a creaking sound, like two pieces of leather rubbing together.
Okay.
And that can be a sign of inflammation around the lungs, like pleurisy.
Wow, so you can hear all that just by listening?
You can. It's amazing what you can pick up with a good stethoscope.
That's incredible. It's like a whole other world in there.
It is. It really is.
Wow, so we've covered the 4 critical life functions.
We have.
We've talked about patient assessment,
Hmm.
things like the CAT scoring system, X-rays,
Yes.
and these amazing abnormal breath sounds.
All essential tools in our toolbox.
Wow, this is fascinating. I feel like I'm already learning so much.
It's clear you're a fast learner.
Well, I have a great teacher.
Well, thank you.
All right, so what else is in this study guide? I'm ready for more.
Let's move on to one of the most important interventions in respiratory care,
Okay.
mechanical ventilation.
Oh, okay, this is the big one.
It is. It's a critical tool, but it's more than just hooking a patient up to a machine,
Right.
There's a lot of nuance to it.
Well, and the study guide gets into the nitty-gritty. It talks about these 4 primary variables that control mechanical ventilation.
Yes. Yes.
Trigger, control, limit, and cycling. It's a lot.
It is. But think of it like this.
Okay.
It's the language of the ventilator.
Okay.
Each variable is describing how the machine breathes for or with the patient.
Okay, so break that down for me. What's the trigger?
So the trigger, that's what initiates a breath.
Okay.
Could be the patient's own effort to breathe,
Okay.
or a set time interval that we program into the ventilator,
Okay.
or even a manual trigger by the therapist.
Okay. So there are different ways to trigger a breath.
Exactly. It depends on the patient's needs and the clinical situation.
Okay, that makes sense. And then control.
Right.
What does that one control?
Control determines how much support the ventilator provides during inspiration.
Okay.
So that could be a preset volume of air or a specific pressure level.
So like how much oof the ventilator gives with each breath.
Exactly.
Huh.
And then we have the limit,
Okay.
which acts like a safety net, you know?
Right, right.
It sets a maximum pressure, volume, or time for inspiration, preventing those lungs from overinflating.
So the ventilator doesn't just keep pushing air in?
Exactly. We don't want that.
Okay.
And then lastly, cycling. This signals the end of inspiration and the beginning of exhalation.
Okay, so it's like the whole breath cycle.
Precisely. It's the complete package.
Right, and the study guide, I thought this was helpful. It visually represents these variables
Yes.
with pressure time waveforms.
It's a great way to visualize it.
It is. You can actually see those plateaus on the graph.
Yeah, plateau pressure.
Yeah, so what is plateau pressure? What does that tell us?
Plateau pressure, it's an essential measurement in mechanical ventilation. It reflects the pressure in the alveoli, those tiny air sacs in the lungs,
Right.
when no air is flowing.
Correct.
This pressure gives us valuable insights into how stiff or how compliant the lungs are, how much resistance there is to airflow.
So it's not just about getting the air in.
No, not at all.
It's about understanding how the lungs are responding.
Exactly.
That's really interesting.
It's about finding that sweet spot
Right, right,
where we're providing enough support,
right.
but not causing any harm.
Without overdoing it.
Exactly.
Yeah.
And, we can adjust the ventilator settings based on that plateau pressure.
Oh, okay. So it's not just about like setting it and forgetting it.
No, not at all. It's a dynamic process we're constantly monitoring and adjusting.
That makes sense. So speaking of monitoring, the study guide goes on to explore all these different modes of ventilation.
Right.
You've got assist control,
Yes.
synchronized intermittent mandatory ventilation, pressure support. There are so many options.
It can seem overwhelming.
It can be a little overwhelming, yeah. How do respiratory therapists decide like which mode is best for a given patient?
That's where the real art and science of respiratory therapy come together.
Right.
Each mode has its own strengths and weaknesses.
Okay.
And we have to really consider the individual needs of the patient.
So like take a assist control, for example.
Okay.
Or AC, I think they call it.
Right. AC, that's the shorthand.
It's a common one, right?
It is. It's very commonly used. And basically, in AC mode, the ventilator delivers a breath,
Okay.
either a set volume or pressure,
Okay.
every time the patient tries to breathe on their own,
Got it.
or at regular intervals if the patient isn't breathing on their own.
So it's like the ventilator is always ready to step in,
Exactly.
but it also allows the patient to take their own breaths.
Precisely. It's a nice balance of support.
That makes sense. And then there's MMV.
Yes, synchronized intermittent mandatory ventilation.
Okay, so that's similar but different.
Similar but different, yeah. So with MMV,
Yeah.
the ventilator still delivers a set number of breaths per minute,
Okay.
but it tries to sync those breaths with the patient's own efforts.
Oh, okay. So it's more about encouraging the patient to participate.
Exactly. We want to wean them off the ventilator as soon as possible.
Right. So you don't want them to become too reliant on it.
Precisely.
Wow. So there's like a whole strategy to it.
There is. It's like a chess game almost.
It is. It's fascinating. And the study guide, I love this. It doesn't just give you the dry technical stuff.
No.
It actually goes into these really intriguing case studies.
Yes, the case studies are great.
I'd love to get your take on some of these.
I'm happy to. I love a good case study. It really gets you thinking.
Okay, so this first one, it involves a premature baby
Okay.
who's on mechanical ventilation.
Okay.
We're given all the ventilator settings and everything, and then all of a sudden, the baby's oxygen saturation drops.
Uh-oh.
Yeah, they turn blue.
Okay.
Their trachea shifts to one side, and breath sounds are absent on the other side.
Wow, that's serious.
Plus, there's a mention of a tympanic percussion note.
Tympanic.
Yeah, I don't even know what that means, but it sounds bad.
Well, putting it all together, it sounds like this little one might be experiencing a pneumothorax,
A pneumothorax?
a collapsed lung.
Oh, wow.
The tracheal deviation, the absent breath sounds on one side, that tympanic percussion note, which basically means a hollow, drum-like sound when you tap on the chest.
Okay.
Those are all classic signs of air leaking into the space around the lung.
Wow, you diagnosed that quickly.
Well, years of experience.
Right, right. So the case study asks what the respiratory therapist should recommend.
Okay.
Should they order a chest x-ray?
That would be a good start.
Okay.
Yeah.
Try transillumination, whatever that is.
That's where you shine a light through the chest
Oh, okay.
to see if there's air trap there.
Interesting.
Put in an umbilical artery catheter
Okay.
or request an echocardiogram.
Wow. So many options. What do you think?
Well, in this situation, time's of the essence, right?
Right.
We need to act fast. So while all of those options could provide valuable information,
Right.
a stat chest x-ray would be the quickest way to confirm the pneumothorax
Okay.
and guide immediate treatment.
And the study guide says that's the correct answer.
So you go.
All right, you ready for another one?
Hit me with it.
Okay, this case is about a patient with myasthenia gravis who's just been intubated,
Okay.
and they show us a chest x-ray
Right.
where the endotracheal tube, that's the tube that goes into the trachea.
Right.
It's way too far down.
Oh, no.
Yeah.
Tube malpositioning.
Is that a common problem?
It can be,
Yeah.
especially if the tube isn't secured properly.
Okay.
And in someone with myasthenia gravis, which is an autoimmune disease that causes muscle weakness, intubation can be even trickier.
Right, because our muscles aren't working as well.
Exactly.
So the x-ray clearly shows that the tube has gone past the carina. That's the point where the trachea branches off into the two main bronchi.
Right.
And it's down in the right lung.
Okay, so that means the left lung is not getting adequately ventilated.
Exactly. So the question is, what should the therapist do?
Okay.
The options are secure the tube where it is,
No, we don't want to do that.
Okay.
We need to fix that.
Pull it back a bit.
That's a possibility.
Okay. Push it in further.
Definitely not.
Okay. Or add air to the tube's cuff.
Okay, so that's interesting.
What do you think?
Well, the key here is to reposition the tube so that both lungs are ventilated equally.
Right.
So gently withdrawing the tube until it sits just above the carina. That's the way to go.
So pulling it back a bit.
Exactly.
And the study guide agrees with you again.
2 for 2.
All right. Last case study. This one's intense.
Okay.
42-year-old woman.
Okay.
She's being manually ventilated after intubation.
Okay.
And the therapist notices that the bag they're using to ventilate her is filling up quickly,
Okay.
but collapsing with minimal pressure.
That's not good.
Yeah. It also says the patient has limited chest movement.
Okay, so putting it all together, it sounds like we might have a significant leak in the system.
A leak?
Yeah, the bag's filling with air, but that air isn't effectively reaching the patient's lungs,
Oh, wow.
hence the limited chest movement.
Okay, so what should the therapist do?
All right, let's look at the options.
Increase the oxygen flow to the bag's reservoir?
Okay, that might help a little,
Yeah.
but it won't solve the underlying problem.
Okay, apply more pressure when squeezing the bag.
Now we're talking.
Okay,
That could help overcome the leak,
okay.
at least temporarily.
Replace the bag's valve.
That could be the source of the leak,
Okay,
but it takes time,
right.
and we need to act fast.
Switch to a different ventilation method.
Again, that takes time.
So more pressure.
In this critical situation, yes, applying more pressure to that bag is going to be the quickest way to address the problem and make sure the patient's getting enough air.
And the study guide says that's the priority.
Of course, we still need to identify and fix that leak, but in that moment, ensuring ventilation is paramount.
Wow, these case studies are amazing.
They are, aren't they?
Yeah.
They really put you in the therapist's shoes.
They do. It's like you have to think on your feet.
Exactly, because in this field, every second counts.
That's a great point. All right, so we've covered mechanical ventilation, those intense case studies.
We're on a roll.
We are. Let's switch gears a bit and talk about arterial blood gases.
ABGs.
ABGs, another essential aspect of respiratory care.
Absolutely. It's like looking at the blood to see how well the lungs are working.
It's like getting a window into what's happening at a cellular level, right?
Absolutely. Those ABGs, they give us so much information.
It's fascinating, but I'll be honest, it's a lot to wrap your head around.
I agree. It can feel a little overwhelming at first.
It does.
But don't worry. The study guide does a really good job of breaking it down.
Okay,
So we're going to make it easy to understand.
All right, I like the sound of that.
Essentially, we focus on 4 key values
Okay.
when we're interpreting ABGs, and those are pH,
Mm-hmm.
PaPi2,
Okay.
PaPa2,
Gotcha.
and HCO3.
Okay, so pH, that's all about like acidity and alkalinity, right?
Exactly. A normal pH should be around 7.35 to 7.45.
Okay.
Lower than that, and we're venturing into acidosis.
Right.
Higher, and it's alkalosis.
And what about the PaCO2?
Right. PaCO2 stands for the partial pressure of carbon dioxide,
Okay.
which essentially reflects how effectively someone is ventilating.
Okay.
In other words, how well are they getting rid of CO2?
So if someone's PaCO2 is high, does that mean they're not breathing effectively?
It could indicate that yes.
Okay.
A high PaCO2 often means there's a problem with ventilation,
Gotcha.
and that can ultimately lead to respiratory acidosis.
Right, because the CO2 is building up.
Exactly. And on the flip side, a low PaCO2 might suggest hyperventilation,
Okay.
which can lead to respiratory alkalosis.
So it's all about balance.
Always about finding that balance, right?
Right. And then there's oxygen, obviously a pretty important one.
Can't live without it.
Exactly. So the PaCO2, what are we aiming for there?
We want to see a PO2 ideally between 80 and 100. That's just the unit we use to measure it.
Okay.
Don't worry too much about that.
Okay.
But the important thing is anything lower than 80.
Okay.
And we're talking hypoxemia,
Hypoxemia meaning?
meaning the blood's not carrying enough oxygen.
Right. Which is obviously a big problem.
Exactly. And then finally, we've got HCO3.
Okay, so that one's bicarbonate.
Right. Bicarbonate. It's like our buffer system.
Okay.
It helps keep that pH in that sweet spot we talked about.
So if the pH is too acidic or too alkaline, bicarbonate can help bring it back into balance.
You got it. It's like a chemical balancing act.
Okay, that makes sense.
And our kidneys, they play a big role in regulating those bicarbonate levels.
Okay, so we've got our 4 key values. We know what the normal ranges are, but the study guide stresses that interpreting ABGs, it's not just about looking at these values in isolation.
Absolutely. It's about putting all those pieces together.
Right, it's not enough to just memorize the numbers.
Exactly. We have to look at the whole picture.
The whole picture, and that includes...
The patient's clinical presentation. So what are they actually like in front of you?
Right, so you're not just looking at a piece of paper with some numbers on it.
No, not at all. We're taking everything into account.
So, for example, the study guide talks about compensated versus uncompensated acid-base imbalances.
Oh, yes. That's where it gets really interesting.
Okay, break that down for me.
Okay, so think of it like this. Our bodies are always striving for balance, right?
Right, homeostasis.
Exactly.
Yeah.
So if there's some sort of primary acid-base disturbance,
Okay.
the body will try to compensate to restore that balance.
So, for example, if someone has respiratory acidosis,
Okay.
meaning their pH is low because they're retaining too much CO2,
Right.
their kidneys might try to compensate by holding on to more bicarbonate.
Exactly. You're getting it.
Okay, that makes sense.
So we'd see that reflected in the ABG values.
Okay, how so?
We'd see a low pH,
Okay.
a high PiCO2,
Right, because that was the primary problem.
exactly, and a high HCO3.
Because the kidneys are trying to compensate.
Precisely. That would indicate a partially compensated respiratory acidosis.
Wow, the body is amazing.
It really is.
Right.
It's always working to keep things in check.
So it all comes back to understanding those foundational concepts.
It does.
Ventilation, oxygenation, acid-base balance.
Absolutely. Those are the building blocks.
And then you can really start to make sense of those ABGs.
Exactly. And speaking of foundational concepts,
Okay.
let's touch on another important one highlighted in the study guide.
Okay.
VQ mismatch.
VQ mismatch, that rings a bell, but I'm a little fuzzy on the details.
Okay, so basically describes an imbalance between ventilation, that's the V,
Okay.
and perfusion, that's the Q.
Right. Ventilation is air, perfusion is blood.
You got it. Ventilation is all about the air reaching the alveoli.
Those tiny air sacs in the lungs.
Right, and perfusion is the blood flow to those same areas. Ideally, we want a good match between the two.
Right, because you need both air and blood for gas exchange to happen.
Exactly, but sometimes things get out of whack.
Hence the mismatch.
Right, so if an area of the lung is getting plenty of air,
Okay.
but not enough blood flow,
Then that oxygen is not going to get picked up very well.
precisely, that's a VQ mismatch.
Okay.
And the opposite can happen too.
Really?
Yeah, an area might have good blood flow, but poor ventilation.
So the blood's getting there, but there's not enough oxygen to pick up.
Exactly, we call that shunting.
Shunting? Why is it called that?
Imagine like a traffic jam in the lungs.
Okay.
The blood is flowing,
Yeah.
but it's bypassing those air sacs where it's supposed to be picking up the oxygen.
Okay, so it's like getting shunted to a different lane.
Exactly. And shunting can be caused by things like atelectasis.
Atelectasis. Remind me what that is again?
Atelectasis is just a fancy word for a collapsed lung segment.
Oh, right. Okay.
It can also be caused by things like pneumonia or even heart failure.
Wow. So many things can disrupt that delicate balance in the lungs.
They can. It's really quite amazing.
So we've talked about VQ mismatch, but how do you actually measure it?
Good question. One way is by looking at the A gradient.
The A gradient, refresh my memory on that one.
So that stands for the alveolar arterial oxygen gradient.
Okay.
It basically tells us the difference between the oxygen pressure in the alveoli
Okay.
and the oxygen pressure in the arteries.
Got it.
So a big difference, or what we call a widened A gradient,
Yeah.
that usually indicates a problem with gas exchange.
Okay, so it's another clue that something might be off.
Exactly. It's all about putting those clues together.
Wow, it's amazing how much you can learn from just a few simple measurements.
It is. It's like detective work, but for the lungs.
Well, I know we can't cover everything in the study guide today.
We could talk about this all day.
No, me too, but we're running out of time. But this has been an incredible deep dive into the world of respiratory therapy.
It really has.
It's amazing how much there is to learn about something as essential as breathing.
You know, it's something we all take for granted until something goes wrong.
It's true. And for anyone out there who's preparing for that respiratory therapist multiple choice exam,
Good luck.
I have a feeling you're all going to ace it after listening to this.
I hope so.
And for those of you who are already respiratory therapists out there, thank you for the incredible work you do.
Here.
You're truly unsung heroes.
I try our best.
Well, keep up the great work, and thanks for listening, everyone.